Going forward, questions need to be addressed. How does the Massachusetts Medical Society remain relevant? How do we measure the real vital signs of our organization? I would like to propose a prescription for both resuscitation and optimal maintenance of disorders that threaten our viability. Number one, addressing the needs of physicians who have cardiac standstill, asystole, is going to be crucial. We learned from Mass Medical Society 2011 index report that 46% of physicians are over 55 years of age. I'm in that group. Unfortunately, the song, The Way We Were, cannot be played. So again, learning about the concerns and deficiency of this segment will help us in the transitions. Another group may have tachycardia. It could be ventricular tachycardia or it could be sinus tachycardia. They are willing to move ahead quickly with healthcare reform, aggressively investigating any new innovation that will help. These docs are excited, but will need more comprehensive tools. Financial and business management, ACO education and training. Number three, respiratory distress. Some doctors are waiting to be intubated so as to let someone else breathe for them. They want to be ventilated. Maybe it's out of frustration or maybe fatigue or even hopelessness. Physicians in this group see all this change and they want support. They want to be protected. They want someone else to breathe for them. Number four, the uninsured. Slightly more physicians are outside of our organization than inside it. You could say that these are uninsured doctors. They wait for an emergency before coming to the society with their emergent needs. We want to help them, but we also need them to be a part of the Massachusetts Medical Society Network family. They are important to us. My challenge to you is this. We own this organization, so let's make it stronger. Let's set a goal for each one of you to recruit at least one member in the next year. The Massachusetts Medical Society is better with infusion of fresh thinking, just as an ischemic limb longs for reperfusion to maintain viability. New voices allow us not only to diversify our thinking, but allow us to better relate to patient needs in a variety of clinical settings. Diversity in the physician workforce is, in every venue, is really crucial. Look at medical schools. At least half of the students are women. This has profoundly altered the culture of medicine in ways that are both visible and not so visible. Even men graduating from medical school express different preferences than men in previous generations. And while minority physicians' numbers have not increased percentage-wise, the population is projected to be greater than 50% by 2040 of minority groups. Our membership still does not reflect gender mix, racial or ethnic diversity. It may in time, as modern medical students fill our ranks, but guess what? We continue to address the concerns of this population and provide value. We can do better. We must adapt. If we could see the society as a human body, some members function as eyes, some as ears, some as hands, yet others as vital organs such as the heart, lungs, and liver. Every organ has a role and is directly tied to helping out and relieving stress and creating functionality. The importance of each cannot be argued. We must be more diligent in learning that what we can offer this new kind of physician, and let's do it quickly. The Code 9 team, number 5. Let me take you back down memory lane to your medical school rotation in internal medicine a few years ago. And I can remember being at the VA in Los Angeles at UCLA. Perhaps you heard code red, code blue, or code 9. You arrived to see docs doing CPR. Probably no ACLS then. Thank you. There are the team leaders. They're all in process. And you know what? There's some who stand on the sidelines, and their role is to support. But they have no clear, direct care of the patient. Now, wouldn't it be incredible if someone in a suit said, give phenylephrine instead of norepinephrine? It's slightly cheaper. Or they said, you've exceeded your hourly global budget on this unrisk-adjusted service patient. Of course, it would have been incredible if this was true. Once in the not-so-distant past, you didn't talk about money and medicine in the same sentence, at least not in polite company. Now let's go back to the real world. The most difficult debate today is the cost of health care. The advent of universal coverage in Massachusetts has improved many things, but it hasn't changed this. If a patient can't afford the medicine, they won't pick it up from the pharmacy. If they can't afford the copay, they won't even make it to the office. This has a direct impact on health and wellness. The truth is that affordability crisis has entered the clinical world. We cannot pretend anymore that it is not our job. Guess what? It is. This is not a comfortable discussion for many physicians. It raises the idea of rationing, which is repugnant to us. It introduces the ethics of business to medicine, which is really uncomfortable. In short, the affordability crisis forces us to think about issues that go against our nature and have conversations that we'd rather not have. We'd rather not talk about it, but we must. We cannot leave the discussion of money and health care to others because we've seen what happens when we do. Imagine the reality of the scenario I just cited. But making a commitment to have these conversations is actually our first step. We must know what to do, we must know what to say, and we must develop solutions that work for everyone. That's precisely the debate that we're having today. We talk about payment reform, we talk about Medicare and SGR. We're talking about electronic health records. We're talking about hospital-physician relationships. As a medical society, we're deeply involved in all of it, and we're making a difference. We know that we have already put an imprint on the payment reform debate. The officers have permeated Massachusetts to discuss payment reform. And more importantly, to listen to you, for you to educate the Mass Medical Society about your concerns, about your experiences over the past 3 years. We have advocated in Washington, D.C., to our legislators, to Secretary Bigby. You heard her today. I think she's seen so much of Linda and I think she might be overwhelmed. She might be sick of us. Same message. She got the song. She understands the words. Our voice has been heard. Thanks to our work, it is now widely accepted that liability reform is a necessary precondition for health care reform. And people appreciated that a robust primary care workforce is critically important to our future. They know that we must talk a fine line between fostering our future healthcare system and ensuring the viability of those who touch the patients. As I said, these issues are already changing our professions, but what we have seen so far is only the beginning. I believe that while changes introduce a notion of vulnerability, it is imperative that we lead the navigation. We lead and show how it can be done to benefit patients and physicians. Our challenge will be to recognize the intersection of opportunity and responsibility. We are physicians. We care for the sick. We advocate for those who are sick. We support the troubled. The future of our profession depends on our ability to capture the essence of our lives. The future belongs to the most adaptable, those who will see the future, create innovations, make it their own, and preserve the essence in the process. That is our challenge in the 21st century, as individuals, as professionals, as a medical society. I know that you are up to the challenge. Mr. Speaker, that concludes my report.